Welcome everyone. Today we'll be doing a brief review lecture on practical ophthalmology tips. The title of this discussion is Avoiding Common Mistakes to Protect Your Medical License. This talk is designed for non-ophthalmology residents, including ER residents, internal medicine residents, or anyone in general that's interested in improving their knowledge of ophthalmology diseases. So a little bit about the content. We're going to talk a little about giant cell arteritis, angle closure glaucoma, central retinal artery occlusions, as well as central retinal vein occlusions, Amaurosis Fugax, and Neuro-Ophthalmology Emergencies. And hopefully this is helpful for treating patients in the appropriate way to protect their vision and possibly even save their life. So giant cell arteritis, let's start things off with a little bit of a question. You're told about an 85-year-old white female who comes to the emergency department on Saturday night with the chief complaint of sudden vision loss in her right eye since awakening earlier in the morning. On review of symptoms, she endorses positive flu-like symptoms, some trouble with eating a regular oatmeal, and night sweats. Which of the following options is the next most appropriate step? So take a look at the options. You can pause the video for a moment, and we'll go ahead and give the answer shortly. So if you selected option C, you chose the appropriate answer. You're going to want to start her on prednisone, high-dose regimen. You're going to want to talk to the ophthalmology service at your hospital. And we'd also like for you to draw a complete blood count, ESR, and CRP lab values to help undergo her workup. Question A is incorrect because this is one of those types of diseases that can end up in permanent blindness if not treated in a time-sensitive manner. Question B, or answer B, is reasonable. However, you're going to want to get the ESR and CRP, and you're not going to want to delay getting the steroids on board for her. CTA is the head and neck vessels is a reasonable idea. We can talk about that a little bit later on in the discussion, but the most critical thing is to get the prednisone started right away and to draw the markers that are common for this type of vasculitis. And then question D is obviously incorrect. So a little bit about giant cell arteritis. Giant cell arteritis, the clinical presentation involves sudden painless loss of vision, typically in a patient above 55 years of age who has antecedent headache, jaw claudication, scalp tenderness, and fever. Many times, patients will also endorse weight loss and night sweats. Really, they just don't feel good when they have giant cell arteritis, and it's typically in the older population. A common exam finding that you can ask about is whether or not they're having trouble chewing up their food. This is called jaw claudication. Key exam findings that you can pick up on are an afferent pupillary defect, which we will talk about in one of the other lecture series, a pale and swollen optic disc with surrounding flame-shaped hemorrhages. And this is demonstrated clearly in Figure 1. We see a pale and swollen optic disc. We see possibly a few flame hemorrhages coming off the disc. And then the pathophysiology to consider here is not perfectly understood. What we do know is that it's an autoimmune condition where macrophages incite destruction within the blood vessel walls. And then as a response to attempt to heal the healing process, myofibroblasts end up promoting extracellular matrix deposition, which leads to the narrowing of the vessel, and this later results in hypoperfusion of the downstream territory. You can think about this when considering a fluorescein angiogram. So essentially what you're talking about is a vasculitis where your immune system attacks the inner lumen of your blood vessels, and the narrowing of the blood vessels results in delayed perfusion of critical areas of the retina. When you have delayed perfusion, you end up getting visual loss. Now the workup, we mentioned this. What do you want to do? You want to get an ESR, a C-reactive protein, which is statistically the most sensitive of the three, and a platelet count, which will be elevated in someone you're suspicious for giant cell arteritis. Again, you're going to want to get steroids on board at a high rate, and you're also going to consider getting a temporal artery biopsy later in the admission course. Let's talk about another ophthalmology emergency you can provide a great deal of help for your patients with if they come to see you with this condition. So another question. A 58-year-old white female presents with a history of farsightedness to the emergency department with a chief complaint of a painful left eye, blurry vision, and nausea for the past 3 hours. In this situation, in the Moonline resident, you're 3 hours away from ophthalmology. What do you think is your next step? So take a second to look over the answers. Go ahead and pause the video. You can come up with a selection. So if you selected answer C, you selected the appropriate choice. You're going to want to check the intraocular pressure. If it's greater than 30, you're going to want to go ahead and give pilocarpine at 2% concentration. This is a miotic agent that we'll explain a little bit more later. You're going to want to start oral acetazolamide, otherwise known as Diamox. You'll also want to start topical timolol drops and brimonidine drops as well to try to get that pressure lower. Now I want you to take a quick look at this photograph. This is a photograph that should be burned into your brain. You have a pupil that's fixed and mid-dilated. You have a cornea that's classically described as steamy, a very hazy cornea. And then you also have a conjunctiva that is extremely hyperemic and congested. So reviewing kind of the other answers why they're incorrect, A is a reasonable thought, but doesn't go all the way with giving pilocarpine. B is unreasonable. When you're talking about giving mannitol, that's a very aggressive treatment that can lead to brain bleeding due to rapid shifts in osmotic gradients. And that's something that needs to be done in the ICU or emergency room setting, not something that you wanted to give and then transfer in an ambulance. And then number D, you don't want to dilate the eye to break the attack. In fact, performing dilation in this situation could actually make the angle closure worse, as we'll learn about. So angle closure glaucoma. Let's talk about the clinical presentation of who's going to come into the emergency room with this issue. Typically, the patients are going to be hyperopic, meaning they're going to have a little bit smaller than average eyes. They're going to be middle-aged. Classically, they're Asian, female. They could be on sulfa antibiotics, or they could be on Topamax for anti-headache or anti-seizure conditions. They're going to complain of nausea. They're going to have decreased vision, periorbital pain, and they'll also endorse some glare around headlights due to the corneal edema. And the key exam findings, we saw it on the previous page. Remember to etch that photo in your mind. You're going to have that fixed mid-dilated pupil, corneal edema, and conjunctival hyperemia. And then every emergency room should have a tono pen to be able to measure the intraocular pressure. Normal range is between 10 and 20. And for angle closure glaucoma, you can get values as high as 50 to 60. If you take a look at the anatomy, it helps, in figure 4, it helps understand what the pathology of angle closure glaucoma looks like. Essentially, you have a lens bulging forward, which blocks the appropriate drainage that you see on the left. Aqueous humor isn't able to get through the pupil and out through the tubercular meshwork that it usually drains from. And this causes buildup of pressure in the eye and can cause irreversible damage to the optic nerve due to high mechanical pressure. So the other things to consider are, how do you work angle closure glaucoma up? Well, the reduction of the intraocular pressure is critical to protecting the optic nerve. You're going to want to give that pilocarpine. It's a miotic agent, which is going to shrink the volume of the iris and pupil down. You're going to want to give intraocular pressure suppressants, as we mentioned. You can give those systemically and topically. All of this is going to provide relief from squeezing on the optic nerve, which is the most critical element to consider. You're also going to call your ophthalmology colleagues to perform gonioscopy to evaluate the anatomy of the angle. And over here in Figure 5, what we can appreciate is the fact that the pupil size has a lot to do with the ability of the eye to drain appropriately. You can appreciate on anterior segment OCT that the angle available for drainage can jump from 3 degrees at a pupil size of 3.85 millimeters to 22 degrees with a pupil size of 2.2. So that's really the critical concept to keep in mind. That's why you give the miotic pilocarpine, and you don't want to dilate in this situation. You want to create as much room for aqueous humor to drain as possible. So let's talk about another subject. Vascular occlusions in the eye. So another question, Tim. You have a 72-year-old African-American male with a previous history of myocardial infarction, hypertension, and hyperlipidemia who presents with sudden onset of painless loss of vision in his right eye for the past 4 hours. The review of systems is negative for weakness, fatigue, or lethargy, making you think that giant cell arteritis isn't on the list. And you suspect a central retinal artery occlusion. Which of the following choices best matches the corresponding fundus exam with the appropriate next best step? So go ahead and take a moment, pause the video, take a look at the figures, and come up with your best selection. So in this scenario, if you chose C, you chose the correct answer. C demonstrates a central retinal artery occlusion. You see the classic pale and white retina overall, and you see the cherry red spot within the macula that we'll talk a little bit more about later. Now, if you were between A and C and went for A, the reason why you're going to want to get the 2D echo and carotid ultrasound is because in some situations, the central retinal artery can be due to emboli traveling from the carotid arteries as well as a cardioembolic valvular disorder. Now, B and D, we'll talk a little bit about those later and go from there. Central retinal artery occlusion. So let's talk a little bit more about this condition. The clinical presentation is going to be sudden, profound vision loss that many times leads to no light perception vision with an associated relevant afferent pupillary defect. We'll talk more about that in another lecture. The risk factors for this condition are atherosclerosis, cardiac valve abnormalities, blood coagulopathies, trauma, and any age over 60. What are some of the key exam findings that you're going to want to pay attention to in central retinal artery occlusion? You're going to see the cherry red spot in the macula. Now, what that is actually intact choroid vessels that provide circulation behind the retina that is lighting up. And then the surrounding pale, swollen retina is due to the disruption of oxygen flow to the outer retina. About 20% of the time, a retinal embolus is observed in this condition. That's why you're going to want to get that carotid ultrasound and also get some imaging of their heart valves. In the pathophysiology, we touched base on this briefly. It's the occlusion of blood flow to the inner retina, which results in cell death due to oxygen starvation. So you can kind of think of it similar to how a stroke works in your brain, the retina just being an extension of brain tissue. The workup, what do we do? So our treatment options in central retinal artery occlusion are very limited and theoretical. There's some techniques that people do try. You can keep the patient supine to help improve perfusion pressure. You can perform an ocular massage. Sometimes this can dislodge the embolus if there is one present. You can put them in a high oxygen environment, or you can do an interchamber paracentesis. The patient, as we mentioned, needs a 2D echo of their heart. They need a carotid ultrasound. They need a hypercoagulability panel to look for risk factors that may lead to a secondary event. Now, it's interesting to note, a recent article published in the Journal of Ophthalmology in August of 2015 noted that there's a very high correlation between patients having a central retinal artery occlusion and being at risk for having a myocardial infarction or stroke. In fact, this study done from Korea by Sung Joon Park et al. Found that patients who have a central retinal artery occlusion have a 44 times higher risk of having a stroke or a heart attack within the first week after their central retinal artery occlusion. Now, this higher risk window actually extends out as well to the first 30 days after the event. Those patients who have a central retinal artery occlusion and are watched for 30 days have a 14 times higher risk of having a stroke or a myocardial infarction. So this is kind of a critical thing to consider. If a patient has a central retinal artery occlusion, your ears need to perk up. You need to do everything you can to mitigate the risk factors for having a stroke, because the odds are that they're more likely to develop one of these complications. So we talked about central retinal artery occlusion. Let's talk about central retinal vein occlusion. That was the options C and D that you saw on the previous slide. So it can present similar to a central retinal artery occlusion, although the clinical presentation can vary based upon whether or not it's an ischemic or a non-ischemic event. The critical risk factors to consider are age, and hypertension is bold because this is the #1 risk factor for patients who develop central retinal vein occlusion. You also need to consider hyperlipidemia, glaucoma, tobacco, and for younger patients, need to think about oral contraceptives. What are the key exam findings to look for? Well, as you see in Figure 7, you have diffuse retinal hemorrhages in all 4 quadrants. You see dilated and tortuous vasculature, and they're not greatly appreciated in this fundus photo, but still worthy to mention is macular edema. The vision in an ischemic version is going to be 2200 or worse. Now you can have a non-ischemic central retinal vein occlusion, and basically what this is going to look like is just a milder version. You might see a few cotton wool spots, and you probably don't see a relevant afferent pupillary defect in that condition. Let's think about the pathophysiology involved. Well, you need to consider the normal anatomy in order to understand this condition. The central retinal artery and the central retinal vein share a common adventitial sheath where they travel together at the lamina cribrosa posterior to the eyeball itself. Atherosclerotic changes of the central retinal artery lead to a bulging and compression of the central retinal vein, which then propagates a cascade of venous stasis, thrombosis, and eventual conclusion. So really the critical thing to know is actually the retinal artery is many times the offending agent leading to a central retinal vein occlusion. So when you have a central retinal vein occlusion, what's the workup you're going to do? You're going to measure blood pressure. As again, we mentioned this is the #1 risk factor to consider. Glucose, you're going to get a complete blood cell count. You're going to study lipids. And you're also going to get a hypercoagulability workup. It's critical to consider the hypercoagulability workup in patients that are younger than 55. It's very likely that they'll end up having something like a factor V, Leiden deficiency, or antiphospholipid syndrome. It's rare for patients under 55 to have central retinal vein occlusions. In fact, one study noted that 90% of central retinal vein occlusions occur in patients over 55 years of age. Now, central retinal vein occlusion is a little bit better to talk about because, as ophthalmologists, we have some options to help patients prevent the further complications of developing this condition. This condition is often titled the 90-day glaucoma due to a cascade of events that is outside the scope of this talk, the patients can end up developing glaucoma due to the leakage of vascular endothelial growth factor. The ophthalmologist who diagnoses a central retinal vein occlusion is going to perform conioscopy to look for any signs of neovascularization of the drainage network of the eye. They're also going to get an OCT to study the fluid levels in the retina, and they're going to measure interocular pressure on a serial basis to help limit further complications from this condition. The OCT itself, if it does show fluid behind the retina, there are options such as corticosteroids and anti-VEGF injections that can limit the damage done by central retinal vein occlusion. Amaurosis Fugax. Let's talk about this condition and go over questions to him. 74-year-old white male comes with a history of tobacco use, hypertension, to his primary care provider for an annual exam. His blood pressure has been well controlled. His hemoglobin A1C is borderline at 7.2, and he's proud of an 11-pound weight loss that he's taken on in the last 3 months. On review of systems, he notes for the past month he's experienced a few episodes of painless loss of vision in his right eye. This has lasted for 5 minutes before resolving on its own. He states it looks like as if he's looking through a movie curtain that comes down over his eye. Which of the following is not a well-described pathologic mechanism explaining his symptoms? So again, take a couple seconds, pause the video, look over the answers. So if you chose answer E, you were correct. A retinal detachment isn't going to be episodic like in Amaurosis Fugax. That's going to look different. Retinal detachments may not be completely obvious when patients are first noticing them, and they may describe a curtain over their vision. That curtain of vision is not going to be episodic. It's going to kind of progressively get a little bit worse, at least in the classic presentation. All the other listed answers can lead to Amaurosis Fugax, and we'll talk a little bit more about that in a minute. So Amaurosis Fugax, it's classically described as transient monocular vision loss that lasts between 1 to 10 minutes with complete resolution of symptoms. Again, different from the retinal detachment because the symptoms are resolved. The key exam findings that you'll see, they may present as an ipsilateral cerebral transient ischemic attack with contralateral neurologic features. So just like patients who develop central retinal artery occlusion, this is similar to a mini stroke, essentially. And in many situations, you can visualize what's known as a Hollenhorst plaque on a dilated fundus examination. So let's take a look at some of these photos. So this is a depiction of the type of visual loss that a patient with Amaurosis Fugax would develop. And then Figure 9 demonstrates a Hollenhorst plaque, which is commonly made of calcium that can be found from a stenotic carotid artery, or also can be shed from a cardioembolic source. What about the pathophysiology? It's kind of similar to the central retinal artery occlusion we previously talked about. You get a temporary reduction in perfusion of the ophthalmic or the central retinal artery. It can be due to embolized stenosis. It can be due to vasospasm from, for example, drug abuse, or it could also be due to autoimmune vasculitis. And the workup that you need to consider is a complete ophthalmologic exam. You need to get carotid ultrasounds. Again, that's the number one. Statistically, the number one source. You want a CT of the head with anyone who's complaining of stroke-like symptoms, memory loss, dysarthria, weakness, things of this nature. You're also going to want to get a CBC, ESR, and CRP to ensure that you're not dealing with something such as giant cell arteritis. And then another thing that's interesting for Amaurosis Fugax, you're going to want to get an EKG. Get that EKG to look for signs of atrial fibrillation. If the patient has atrial fibrillation, they're more prone to developing clots along their heart valves and developing complications associated with that. So the last subject I want to talk about is Neuro-Ophthalmology Emergencies. So let's go with a question sim. So you have a 31-year-old white female who comes to the emergency department with a chief complaint of 2-day history of dull ocular pain and double vision, which has progressively gotten worse. The exam shows the following movements on attempted gazes in all 6 cardinal directions. Which of the following is the next best step? So take a second to pause the video and review the gaze attempts by the patient. So if you selected choice A, you were correct. We can talk through this a little bit. Choice C is wrong because that's not really, you're missing the point if you think this is an infection. The number one thing that you need to be concerned about in this patient is an acute third nerve palsy. You've probably learned about this in medical school before, but it's important to review again because this is something that you can do to save a person's life potentially down the road if you understand this well. So let's review some of these movements. Now, your third ocular nerve does a tremendous amount of controls a tremendous amount of the eye movements. And we can see in this photo that the patient clearly has a lesion of their right third nerve. How do we know that? Well, the patient, for example, has ptosis, which is due to which is explained by a deficit in the levator muscle, which is controlled by ocular motor nerve 3. The patient has an inability to adduct, which is controlled by a deficit in the medial rectus, controlled by ocular motor nerve 3. The patient also demonstrates an inability to look up, which indicates a limitation in the superior rectus, controlled by ocular motor nerve 3. And the patient also demonstrates a deficit in the ability to look down, which indicates a deficit in the inferior rectus, also controlled by 3. In fact, the only action that this right eye is able to do is to look outwards. The lateral rectus is intact, and this is controlled by the 6th nerve. So you're going to want to get an urgent CTA of the head and neck to rule out a posterior communicating aneurysm. This is something that's absolutely critical for you to burn into your brain because you can really end up helping someone out a great deal. So let's review again kind of the clinical presentation of how this patient will present. The patient will present with an intense, dull periorbital pain. They'll mention double vision because of their ocular gaze paresis that we just talked about. And they'll also have an eyelid droop. The key exam findings to remember are to look for that eye that is down and out. Again, there's the only preserved right lateral abduction movement, as we just saw. They're going to have the ptosis. They're going to have a pupil that's fixed and dilated, and they're going to have the listed gaze deficits. The pathophysiology is actually relatively simple to explain. You have your internal carotid artery, and you have the posterior communicating artery. If there's a ballooning of that posterior communicating artery, otherwise known as an aneurysm, that compresses the ocular motor nerve, it's going to limit the ocular motor nerve's ability to do its job, which is constrict the pupil, which is move the eye up, down, and medially, and it will also affect the levator muscle, which gives it the ability to prevent that ptosis that we saw. The compressive PCOM aneurysm is the number one thing I want you to take away from the presentation on acute third nerve palsies. However, there are other conditions that can cause it as well that you need to think of, such as a cavernous sinus thrombosis, pituitary apoplexy, or various tumors. And the main thing that you need to remember is that in the workup, you need to order emergent cranial imaging with early communication to the neurosurgery service closest by. Now, the reason why in the previous slide that CTA was chosen is because in general, it's going to be a quicker study, and these patients are ticking time bombs who you want to get to in front of the neurosurgery service as soon as possible.